Good morning, everybody. This is Mike Fraser. I'm the Chief Executive Officer at the Association of State and Territorial Health Officials, and we're pleased to offer you this opportunity to connect with subject matter experts and leaders from across the country. As you all know, we are facing the emergence of what we term the O variant, a variant about which we don't know much, but we're certainly, like the president, concerned about it, but not panicking. And that will be one of our messages from our team. We're tracking it closely, and ASTHO is in touch almost daily. Well, certainly daily, almost hourly, with all state health officials, with our CDC partners and other leaders at HHS and the White House to understand the situation. But we appreciate the opportunity that you to share with you what we know and what states are doing, as well as address any questions you have. And also, as you all know, the president is releasing his winter plan to address COVID. We had the chance to get a copy of that this morning and have looked at some of the details there, and we can certainly comment on that. This call is on the record, and we welcome your questions. Stephanie will be moderating the Q&A through Zoom. Certainly, there's a lot going on, and I want to introduce our panelists. Our first panelist is Dr. Nirav Shah. Dr. Shah is an MD, JD, and director of the Maine Centers for Disease Control in Augusta, Maine. He's also ASTHO's president. We're also joined by ASTHO's chief medical officer, Dr. Marcus Plescia. Dr. Plescia is a family physician and formerly served as health director in Mecklenburg County, North Carolina, as well as other positions. And we're really pleased to have with us a partner of ASTHO's from the Association of Public Health Laboratories. Kelly Wroblewski is director of infectious disease, and Kelly in particular can comment on lab readiness and some of the actual good news we have around genetic sequencing and the opportunities we have to identify the O variant, and talk a little bit about what our laboratories are doing when it comes to preparedness. So thanks to all three of you for joining. We will not do any opening remarks. In fact, we'll turn it over directly to you all, the press, our partners and friends, to ask questions of any of our experts. So please queue up. In the meantime, we will say ASTHO is, as I mentioned, you can queue up by raising your hand using Zoom. ASTHO is in the process of reviewing the president's plan, and there's certainly aspects about that we are really excited about. And I'll actually, maybe Nirav, just ask you to start with that if you'd like. Just thoughts on the president's plan to get us going.
Sure thing. Good morning, everyone. We again thank you all for hopping on today and joining us. We're very delighted to be able to chat about the Omicron variant and the path forward as outlined in the plan. Again, as Mike mentioned, my name is Nirav Shah. I have the privilege of serving as ASTHO's president right now. I'm also the director of the state of Maine's Center for Disease Control and Prevention. I'll just make one or two very quick comments. First, about Omicron. As folks are aware, the World Health Organization has labeled Omicron a variant of concern, which is about right. The question now scientifically is whether or to what extent Omicron will become a threat. There will be, as we've seen throughout the pandemic, a scientific process that unfolds before our eyes once again. And until all of those data are in, the view of state health departments and state health officials is that caution is warranted. Indeed, our advice to the public today is the same as it was yesterday. Get vaccinated, get boosted, wear a mask, so on and so forth. We're delighted to see that President Biden and his administration have released a plan for getting us through this latest winter surge, as well as how to contend with the possible threats posed by Omicron. There are a few things that I will just note very quickly. The first is that we appreciate and concur with the importance of testing, particularly increasing access to testing through various and different coverage and reimbursement means. And then second, we agree with and applaud the fact that the president is taking a holistic view, whether it's recommending and continuing the requirement for masking on public transportation, as well as continuing providing funding for health departments, as well as support for genomic surveillance, which Kelly can discuss. This is an all options on the table approach, and we're delighted to see the administration continue to move forward with that, particularly with respect to staffing. Staffing at the state level has remained a challenge. We're delighted to see the president free up additional federal assets that can assist states right now. So with that, we thank you all for hopping on, and we're looking forward to the dialogue.
I'm going to call on Sheryl Stolberg from the New York Times.
Thank you for doing this call. I'd like to get a comment maybe on two aspects of the president's plan. First, he is putting more of an emphasis on testing. He's going to ask private insurers to pay for at-home testing. And I'm wondering if you can talk about the importance of testing and how this might be a benefit in controlling the spread of the virus. And then secondly, the president does not appear to be asking governors to reimpose their mask mandates. Right now, only 6 states have mask mandates regardless of vaccination status. And I'm wondering if you think it's time for states to begin reviving those mandates.
I can go ahead and start, Sheryl, and then again, I'll invite Marcus and Kelly to weigh in as well. So with respect to testing, in particular, that was, to me, one of the hallmarks of the winter plan. We concur with the fact that testing is of paramount importance right now. Indeed, I think for this next phase of the pandemic, rapid access to rapid testing will be key, whether it's contending with potential surges driven by Omicron, or looking at rapid access to oral antiviral therapies like molnupiravir and Paxlovid, both of which will need to have rapid testing. On top of that, as we see compliance coming in with the OSHA mandate, which is of course on hold, but to the extent it moves forward, having rapid access to rapid testing at home, all of those will be critical for the next phase of the pandemic. The coverage and reimbursement aspect is essential. I don't want us to lose sight of the supply itself, though. It's great to see that coverage may be more easily accessible and attainable, but we need to make sure that the supply is there to meet that forthcoming demand. Right now, several states rather, are having challenges acquiring large volumes of, say, the Abbott Binax Now product, which has become a staple in so many venues. So coverage and reimbursement are critical. We want to make sure that the supply is there to meet that demand. With respect to mask mandates, it's something that I suspect is under discussion in different states. The question that comes up when you think about something like the reimposition of a mandate in an indoor public setting, I think there are two questions. Number one is that where the transmission is happening? I will say, at least in the epidemiology in our state here in Maine, we see the bulk of transmission occurring when we do case investigations in private, indoor, home-based gatherings, rather than in necessarily indoor public settings. I'm not saying that there is no transmission happening in such settings. It's just that the bulk is happening in private gatherings. That, coupled with the fact that any mandate of that sort necessitates having an enforcement mechanism, which in prior times, in the summer of 2020, many states had the wherewithal to do. Right now, given the other operations that are on the table, enforcement becomes an even bigger challenge given staffing. I think those are the considerations that governors are weighing as they think through the calculus of mask mandates. Over.
I'll just add a couple of quick comments. First of all, with regard to masks, with regard to testing, there's been a couple of times where we've made really substantial progress with our response to the COVID pandemic. Vaccinations, monoclonal antibodies, and I think the testing is now the latest breakthrough. I mean, having these tests that can be done so easily at home can make a huge difference in infection control. A lot of people who've not been willing to adhere or comply with some of the testing requirements will do that when they can do that in the privacy of their home and with tests that are easily available and convenient. Now, we do need tests that are easily available and convenient. And I think one of the themes you'll hear is, it's good to see the president addressing that. We need more tests on the market, and they need to be less expensive. The second thing is around masks. Masks work. I mean, I know there was a lot of confusion about that early on, but masks are an effective way to prevent passage of the COVID virus. And so I do think that may, as we learn more about the Omicron variant, that may be a factor that we really have to call into play.
Thank you both. Looks like David Lim with Politico is up next.
All right, thanks for taking the question. I just want to follow up on the at-home testing policy from the tri-agency guidance that is going to be amended. Could you speak a little bit, as you mentioned supply being potentially an issue, Could you talk about, would it be more effective if the government was able to procure these tests and distribute it through public health departments? Is this the most optimal way, in your view, to kind of distribute these tests to the populace that needs these?
I'll start there, but again, Kelly and Marcus, I'm not sure. I don't have strong feelings. There's a sort of an immutable iron law when you think about government procurement. The federal government can give states money to purchase the products, or the federal government can purchase the products themselves and then distribute them to the states. And there are various and different trade-offs between both of those models. Early on in the pandemic, the prior administration, very, very early on, purchased the products and then distributed them to states. I'm thinking of the ID Now device. More recently, it's been through a funding model, leaving states to purchase it. Again, there are pros and cons. I think right now, for where we are, providing states the funding to then go to the market off of the federal supply schedule to purchase the tests that work for them affords states maximum flexibility. So I think that model right now is the right one for where we are. The key will be to maximize the market availability. The test that a lot of states rely upon heavily is the Abbott Binax Now test. It's one that we're aware of. The folks that we subsequently give tests to know how to use it. And so there have been some challenges with obtaining those tests. It's no question, there are other tests on the market, and we're expanding our portfolio to accommodate those and use them. But the market leader is really the Binax Now. Having more and ready access to that would be a great help right now.
Just to clarify, specifically on the individual submitting reimbursement to private insurance to obtain reimbursement for tests that they already purchased was what I was referring to. But could you speak a little as to if that's a good plan for distributing at-home tests?
I think it is. I hear it. I'm sorry. I understand your point now, as opposed to states acquiring them and shipping them out. Understood. Yes, I think the reimbursement model works well, again, provided that it's coupled with easy access to the tests on the open marketplace, provided that folks can go to a Walgreens, purchase the test, and have at the point of care their insurance charged and adjudicated so that they're not charged at the cash register or being able to submit for reimbursement. That's a very efficient model. It's something that we've used throughout, whether it's for prescription drugs and other things. I think the key here is just making sure that the tests are there.
And just to follow up with Dr. Shah, this is Mike Fraser. I mean, one thing that ASTHO has been talking with our partners at the Council of State and Territorial Epidemiologists about is, should those tests come with some kind of easy to understand insert that helps folks understand what to do with a positive result or a negative result. There is some concern that with the increase in at-home testing, getting those results reported to state health departments might be difficult because the result doesn't automatically go to public health authorities. So that is something that we're looking at now, potentially for a future development.
All right, up next we have Meg Tirrell with CNBC.
Hi, I'm wondering, have you heard about any other states working to verify cases of Omicron right now? And also, I'm just wondering if you can reflect on just sort of the profile we've been hearing about so far, given that it's very limited data. And here in the US, we just have 2 cases to know about, but both people fully vaccinated, mild symptoms resolved. There seems to be a narrative that's going around that could be, okay, maybe this does evade our vaccines protections or reinfect people who've had COVID, but it seems to be mild so far, so maybe it's a good thing. How do you just look at all of that data?
Marcus, you want to start this one?
Yes, I mean, I think you're raising really valid points. I mean, we just don't know a lot about this variant. I think our approach has been, prepare for the worst, hope for the best. There are concerns about the impact it might have on the vaccine. So far, we have also seen that the cases that are being reported are mild, although that just may be a matter of, where the outbreaks have been occurring. Ultimately, what I would say is this is the foreseeable future. We've all talked about having this pathogen become endemic, meaning it's going to be around for a while and we're going to be dealing with it. And we're going to have these same kinds of issues pop up where there's a new variant, and we have to look at what the implications of that might be. I mean, I think our message to the public is that we see this as the future, but we're not going to be complacent about it. I mean, every variant has to be taken very seriously, and until we know more, we have to prepare for the worst. And I think that's what we're seeing is going on with this.
Meg, I would only add, I concur with Marcus. This will be, in some respects, the ebb and flow of the future. Just to be straight with the virus is going to virus, right? And we've just got to make sure that we're ready from a surveillance perspective, from a disease control perspective. That's what state health departments do. And in that respect, we are ready and have been ready for the introduction of something of this nature. The other thing I would caution at this point is overinterpretation of a few data points. Without knowing the things of, for example, the age of the individuals, whether they had pre-existing health conditions, so on and so forth, it's difficult to really draw any conclusions. Old saying of, the plural of anecdote is not data applies with particular force here.
All right. Brenda Goodman with WebMD. Next.
Hi, can you hear me?
Yep, we can hear you.
Thanks. I have a couple of questions. They're both related to testing. I'm wondering, do we know for certain that the rapid antigen test can detect Omicron? And the other question is related to labs that sequence the S gene dropouts. I heard from APHL that there might be some backlog of that sequencing, and I'm just wondering if anyone can give us an estimate of how many days or weeks backlog we have for those samples. Thank you.
So I can start with your first question about the performance of antigen tests. So FDA has collected some preliminary data on performance of antigen tests against Omicron, and it appears that all of the available antigen tests on the market will detect it. And then regarding your question about backlog, I don't know. So if you heard it from APHL, that would be us. And I'm not sure exactly what we said about backlog. There is sort of a delay just inherently in the time it takes to collect a specimen to the time you get a sequence result. Just inherently in the process for sequencing. So you take a specimen, you do a diagnostic test, you get a result, and then you would sequence it. And then depending on the sequence method, if you're doing high throughput sequencing where you're testing lots of specimens at one time, that process can take a full week. If you're doing smaller runs, which when labs detect an S gene dropout, in both of the cases where we've identified cases so far, the labs that detected the S gene dropout then went forward with a different sequencing method that allows for smaller runs and faster turnaround time. You don't necessarily have that delay. And so right now, most public health laboratories at least are using both approaches. So they're still sequencing lots of specimens at one time using that longer process. But if they do detect an S gene target failure or S gene dropout, then they use that method that's a little bit shorter and will give you a faster result. Did that answer the question?
I think so. I think maybe I misunderstood. So the sequencing happens at the same lab then that would detect the S gene?
In some cases not. It really depends on where that diagnostic test is first done.
And about how long does it take? Because I'm wondering the tests that have been positive so far that we found for Omicron have been from roughly November the 22nd-ish. And I'm just wondering how long that takes on average to have a definitive result.
Yeah, I think that's just really hard to say because it's dependent so much on the time that if a patient has a rapid test, for example, they wouldn't know, they would have to go back to a lab and get a specimen to either be sequenced or tested with something like TACPAT that's going to find the S gene target failure. So having sort of a definitive timeline or turnaround time to detect a variant is just really hard to estimate.
Okay, thank you.
Okay, Eric Berger from The Guardian up next.
Yeah, thank you. I wanted to ask if testing is the latest breakthrough and something that public health officials will be pushing for. Do you expect it to run into the same sort of resistance that calls for vaccination and masking have faced earlier in the pandemic, or is this less vulnerable to politics?
Boy, I'll start because in this day and age, it seems like even the most apolitical or non-political things can be susceptible to political change. But there seems to be some degree of agreement that testing is not of the same manner that vaccination or perhaps masking are. It doesn't have that same talismanic feature. It's just something you swab in your nose and then you're done. So thus far, we have not seen resistance to more widespread testing, even indeed in places like schools, where many states have been using pooled testing to test a large number of students in the classroom in order to keep them safe. We have not seen widespread resistance to it. However, I think the asterisk to that is if we get to a world where the options on the table for employers or schools, for example, are vaccinate or test or be vaccinated or be tested, we could see testing take on a distinctly more political dimension. We haven't seen that quite yet, but that would be something I would be looking for on the horizon. Certainly testing is something that's quite accepted. We're all used to getting tested, whether it's our cholesterol or what have you, and testing for COVID, I hope goes that route. But Marcus, Kelly?
Yeah, I'll just add, I think the one thing that is perhaps going to be the most tricky about testing is, I think people may test now that it's easy to do and you can do it confidentially. The question is what you do with the results of those tests. And what's going to be really important is that if somebody tests positive, we need a new social norm. When you test positive, when you're sick, you stay at home. And when you're sick, you let other people that you might have exposed know. We in public health will be glad to help you with that through contact tracing, but that has gotten political. And so it's fine. If you don't want the public health agency to help you with that, that's okay. But then you have a responsibility to let people know yourself. And that's going to be the real question with testing. I think people are going to really use these new tests, but the question is what will they do with the results? And that's the message we need to drive home.
All right, Emily Kopp with CQ Roll Call.
Hi, thank you for taking my question. I'm curious, how much do we know at this point about how boosters could affect the epidemiology of the Omicron variant? And I'm also curious where we stand as far as expired doses. Have we been seeing vaccine doses expire and are more at risk of expiring? And could boosters help with that? Just hoping for a progress update on that.
Sure, I can start with the booster piece. The bottom line there is less is known about the implications for boosters on conferring protection against Omicron right now. There are some good hypothetical reasons or hypotheses that someone who has received a booster will have an extra measure of protection against Omicron. This is based off of data that came out about a week and a half ago that suggested that antibody levels after someone had received a booster, in fact, surpassed even the levels that they received after their primary series. So there's encouraging laboratory evidence, but the analysis doesn't stop there. We need to go from the laboratory to the field and do the proper vaccine efficacy studies with the Omicron variant to determine really how much marginal value the booster is adding. We all suspect that it will add significant marginal value, but will it reduce the likelihood of breakthrough cases? That's the question on the table. Virologists and immunologists with whom I've had the pleasure of speaking in recent days are optimistic on this front, but again, plural of anecdote, not data. Until we get all the data in, we can't really say for sure. With respect to expired doses, Marcus, I'll ask you here, but we had a bit of a time back in August and September where before boosters were widespread, Some states did report some doses that were expiring, but as boosters started coming online, I can tell you in my state, we have not had any issue with doses expiring on the shelf.
Yeah, and I mean, I think there's been a number of times where we've gotten kind of close on having some of our vaccine supply expire, and then we've had the FDA give some lengthening of the expiration date. So our sense is that, you know, overall there's been remarkably little waste of the vaccine, and for a rollout as comprehensive and challenging as this, you know, I think that's quite extraordinary. The one other thing I'll add about sort of the continued effectiveness of the virus is, you know, one of the other messages we want to really make sure that the public gets is these are really, really effective vaccines. You know, 90 to 95% effectiveness, particularly with boosting. Most of our other vaccines aren't that effective, and yet they work extremely well. So, you know, we're concerned about whether there might be some diminution of effectiveness with this new variant, but we do have a little bit of a fudge factor. I mean, I think even with the vaccines becoming slightly less effective, they're still going to continue to be our best tool.
Laurie McGinley, with the Washington Post. Next.
Thank you. Thank you so much for doing this. I have two questions. One is on supply. I can hear the urgency in your voices on that. How do we get more supply at this point? Can the administration do more? And why are we in this situation at this point of shortages of these tests? And the second question about testing, just following up on David Lim's question about reimbursement. So just so I'm clear, would it be your expectation that when people go to buy the rapid tests, that they just show their insurance card and they don't have to lay out any money? Or do you think that they have to pay, go home and file? Because some people have been saying that the latter will not be doable, really, will not be good. Thank you.
I can start with the latter question there. Laurie, it would be my hope. I don't know if I would frame it as an expectation, but it would be my hope that the way that the private insurance coverage and reimbursement were handled would be via adjudication at the site. That is to say, you present your insurance card and the claim is made and processed and approved in real time right there. That's relatively commonplace these days, whether it's for getting your flu shot or indeed the way that a lot of prescriptions, whether under Part D or in just the private insurance market, it's the way that a lot of those are adjudicated. I think lumping in, or for those with health savings accounts as well, lumping in the COVID test under that model would greatly expand access. As you intimated, a pay and chase model where individuals have to have an expenditure out front and then get reimbursed for it, that introduces an access challenge for a lot of folks. So that would be, I think, our view that it would be preferable to expand access in that manner. As to the former, about the supply of tests, I am not sure, to be totally straight with you. I've tried to understand better the relevant differences between the US market and the European market with respect to the availability and supply of testing. And I have not developed sufficient expertise on that to comment. I'm not sure, but Marcus and Kelly would know better than I.
Well, I'll say broadly, I mean, this is an important issue. I mean, removing cost barriers to any public health intervention, particularly to vaccinations, immunizations, is an evidence-based approach. I mean, that works. The more you can remove barriers, and particularly cost, the more uptake you're going to have on participation with things. So I think that's going to apply to testing. You know, the challenge that we hear from our membership is that although we do have substantial amounts of federal funding coming into state and local public health departments now, you know, paying for things like testing and other services is a big pull on those resources. And, you know, we can use those resources for that, but we need to make sure there's ample resources that we can also cover some of the other needs that have been unearthed by the COVID pandemic. And so, you know, I think it's a bit of a national question of how are we going to pay for these? Are we going to go through the private insurance thing? Or are we just going to make them free for everybody, which would obviously be effective, but also could get quite expensive? You know, But the science shows if you remove cost barriers, you'll get a lot more people to comply with whatever the intervention is.
What I'll just say, as far as supply chain goes, is I think the key for home tests is going to be to diversify the supply chain, meaning adding more different manufacturers beyond Buy Next Now. I understand as far as when you're talking about schools that have been trained and have staff trained and not wanting to retrain, I do think that's an important point. But as far as individuals doing home testing, if we can have more manufacturers in the market, that's the way to expand the supply. We've had to do that really early in 2020 with laboratory testing supply and diversify the lab tests that were being used. And that was really the way out of that challenge. So I think that the same applies here with home-based tests.
All right, yep, Dan Goldberg with Politico.
Hi, thanks so much for doing this. Dr. Shah, this question's for you. What have you, about booster shots? The uptake has been relatively slow. I know Maine is doing better than most states, but I'm curious what you're hearing from people on the ground or from your colleagues in other states about why is there a messaging problem from state and federal government? Is waning immunity not a concept people are understanding, or is there fatigue? What do you think is going on about the low uptake in boosters?
Yeah, that's a great question. I'm going to invite Marcus and Kelly as well to weigh in. We've been pleased, I would say, with the uptake in Maine, but we're looking to do better. I'll spotlight a few factors, Dan, that have emerged just in the recent days. I don't know which of any of these predominates over the others. As with a lot of complicated systematic problems, it's probably a constellation of all, but let's start with the messaging. It's been confusing. We should just start with that. The distinction between can get a booster, should get a booster, was unhelpful. And I understand what the genesis of that is. ACIP is a committee of physicians that writes guidelines for other physicians. And in the minds of physicians, the distinction between can and should means something, but in the minds of non-physicians, it is difficult to parse that line. So that at the outset generated confusion. If we've learned anything during COVID about messaging, is that clarity is key, and introducing judgments and discretion will just lead a lot of people not to dig deeper. Should I, can I, may I? It'll just lead them to do nothing. So that, I think, out the gate hampered booster availability and uptake. We here in Maine, if I may be immodest for a second, tried to collapse that distinction a couple of weeks ago, and we just said everyone should get one, period, go. But that was part of it. More recently, Dan, we've seen some concerns, at least in the Northeast, about access. Pharmacies particularly, which have been a channel that have been used for vaccinations, that have themselves been grappling with staffing challenges, and at least in the Northeast have had to cancel appointments as a result of that. I've heard that happening from as far as Maine down to Maryland, where I've heard folks saying they were scheduled for a booster at a commercial pharmacy only to go there and find it to be canceled. So access has been a challenge more recently. Then third, it's not clear to me that we've made the case. So the first category, can versus should, those are folks that are at the outset interested in getting a booster, just aren't sure if they're eligible. But there's another larger category of folks for whom we haven't made the case for a booster yet. Whether it's waning immunity, the incursion of Delta, what have you, we haven't made the case for why a booster is necessary. That's concerning because these are folks for whom we did make the case for the importance of vaccines. We just haven't followed that through on the importance of boosters. I'll stop there in order to give others a chance.
I think Dr. Shah really kind of summed it up. I mean, the only thing I would add, and this is really more from my experience as a medical care provider, is, you know, for a lot of people, particularly for a lot of adults, you know, the decision to get the primary series was a big step. I mean, a lot of adults are vaccine hesitant. And so I'm not terribly surprised that there are people out there who eventually got the first series, but who are a little reluctant or are going to take a while to come around to get a booster. I mean, we're having to overcome some of the same issues around their vaccine hesitancy. And, you know, I just think we're going to have to persevere on this and give it some time. We're not, I never expected to have the same kind of demand as we saw for the primary series with the booster.
And I'm sorry, Dr. Shah, just to be clear, when you talk about access issues, you're not talking about the supply of the vaccine itself. You're talking about, there's no staff at the Walgreens.
Correct. Yep. In fact, Dan, in the case of at least Maine, when I started seeing those complaints surface on social media last Friday, is when I really started seeing them in earnest on Twitter with people tagging me saying, hey, what's up? I sent out a note to the Walgreens corporate folks, which is the one chain where it's been reported, although we've seen it in others, and said, I need to know the diagnosis of this problem, because if it's a vaccine supply thing, I can help with that. And uniformly, what I got back was it was staffing.
Thank you.
Did I just implicitly endorse the value of social media? Jeez, I gotta watch myself.
I was thinking about that. Brianna Abbott from the Wall Street Journal.
Hi, thanks for doing the call. I have a quick testing question. And sort of in the hunt for the Omicron variant, I know that only one test so far, the TACPath test, is the one that actually has the S gene dropout. And I'm wondering if there are any supply concerns of that, if labs are trying to get more access to that test, or if that's just not a concern.
Yeah, we've been in touch with Thermo Fisher, and it doesn't appear to be a concern based on what the demand is. We've been trying to get some data on what labs are projecting as far as their needs over the next few weeks, and Thermo Fisher will have plans to ramp supply accordingly.
Great, thank you.
All right. Are there any extra additional questions? I don't see any hands up.
Great. Well, thank you, Stephanie. And thanks to our media partners for joining us, obviously to our experts, Dr. Shah. We appreciate you, Kelly, Marcus. Thank you all so much. If you do, if anybody wants to follow up individually or is looking for a health officer in a particular state or region, please feel free to call our PR team, pr@astho.org or media@astho.org, and we'll be happy to connect you. Obviously, with the O variant, there's a lot to come, and we may want to talk again. And certainly, as we look forward to December 14th, as the one-year anniversary of the first vaccination in the United States, we look forward to hosting another event, but also progress and continued challenges we rest in the vaccine campaign. So a lot more to come in a busy month for all of us. Thanks again, and please do reach out at media@astho.org if you need anything for any stories or background that you're working on. Have a great rest of your day, and we will look forward to working with you in the future.